So I'd like to welcome all of the attendees who have joined us today and to those joining via the recording to the North Simcoe Muskoka Specialized Geriatric Services Practice Short for September 2021. My name is Jackie Saul, and I am one of the Psychogeriatric Resource Consultants with North Simcoe Muskoka Specialized Geriatric Services. Please note that invitations to this practice short have been extended not only to the SGS team, but to system partners, and we welcome everyone today. Today's session is being offered through Zoom webinar. All participants are muted and videos are off. Please note that there is a chat box at the bottom of your screen for you to share with other participants, and also a Q&A section where we ask that you write any questions you have for the speaker. The Q&A section will be monitored throughout the session. Today's session is being recorded and will be accessible on the SGS website under the Education tab, under Monthly Education. For those of you who have missed prior practice shorts, you will find the recordings in this location. If you are watching the recording, welcome. And a reminder that if you would like to join live, practice short sessions are offered the second Friday of the month at 8:30 and are 30 minutes in length. Last year, our practice shorts focused on the COVID-19 pandemic. As we began to plan for this practice short series, we wanted to focus on the 3Ds: dementia, depression, and delirium, and what was new in respect to clinical best practice. Despite having lived and worked through a global pandemic over the past 18 months, there have been a number of updated guidelines and documents released related to the work that we all do. The focus of this fall practice short series will be the 3Ds. Today, we are pleased to have Kim Simpson, PRC, present on the 2020 report of the Lancet Commission. On October the 8th, Dr. Jeff Daniel, geriatric psychiatrist with NSMSGS, will present on the Canadian guidelines on prevention, assessment, and treatment of depression among older adults, which was updated in June of 2021. On November 12th, we will focus on the Health Quality Ontario Delirium Quality of Standards. And in December, we will focus on the Canadian Consensus Conference on the Diagnosis and Treatment of Dementia Guidelines. I am pleased to introduce Kim Simpson today. Kim is the Psychogeriatric Resource Consultant supporting Barrie and area. She is an occupational therapist who has worked in seniors care for over 20 years. She has been in the PRC role since 2015. Prior to that, she worked at the Horizons program at Waypoint and has extensive experience in mental health care. Now over to Kim.
Thank you, Jackie. So today I am going to take the next 20 minutes or so to review the Dementia Prevention, Intervention, and Care 2020 report of the Lancet Commission that was released in August of last year. The report is readily available online, and the link to the report is being shared in the chat box. This is going to be an overview of the report and the recommendations, and I encourage you to read the report for more details. As I move through the next few slides, I would encourage you to think about how this information relates to your clinical practice and how some of this information might be incorporated, new information might be incorporated into your work and our advocacy as a health system. The document provides context regarding dementia. 50 million people worldwide have dementia. This number is projected to increase to 152 million by 2050. We know that the prevalence of dementia has remained stable since 1990, but due to an aging and larger population, the number of people living with dementia has more than doubled since 1990. This figure is particularly rising in low-income and middle-income countries where 2/3 of people with dementia live. Dementia affects individuals, their families, and the economy, with global costs estimated at about $1 trillion annually. 3 new modifiable risk factors were added to the 2020 report. Previously, 9 modifiable risk factors for dementia had been identified in the 2017 Lancet Commission report. We will be reviewing the modifiable risk factors in the coming slides. 40% of dementias may be prevented or delayed by addressing the 12 modifiable risk factors. As I mentioned, with the 2017 Lancet Commission report, there were 9 modifiable risk factors identified for dementia. The recent review of evidence and report has added an additional 3 risk factors. The modifiable risk factors include education. We know that higher childhood education levels and lifelong educational attainment reduce dementia risk. There are some studies that support cognitive maintenance as having some protective effect on developing dementia. The use it or lose it hypothesis suggests that mental activity in general might improve cognitive function. The next modifiable risk factor is hypertension. Persistent midlife hypertension is associated with increased risk of late life dementia. Therefore, controlling and treating hypertension can modify dementia risk. Hearing impairment is the next modifiable risk factor. Hearing impairment is the highest population attributable fraction for dementia, meaning that it is the #1 modifiable risk factor. There is an increased risk of dementia per 10 decibels of worsening hearing loss. In a 25-year prospective study of over 3,700 people aged 65 years and older, it was found that increased dementia incidence in those with self-reporting hearing problems, except for those with hearing aids. What's been found is that immediate and delayed recall deteriorated less after the initiation of hearing aids. Smoking is the next modifiable risk factor, and we know that smokers are at higher risk of dementia than non-smokers, and stopping smoking even when older reduces this risk. Secondhand risk exposure has been associated with memory deterioration as well. Obesity. New evidence supports the relationship between increased body mass index, or BMI, and dementia, and from a review of 19 longitudinal studies of people aged 35 to 65. A greater BMI, greater or equal to 30, was associated with later life dementia. Depression is the next modifiable risk factor. Excuse me, and we know depression is associated with dementia incidence. Depression, although as well, is also part of the prodrome or early stages of dementia. Physical activity. So there's convincing evidence for physical activity in protecting against clinically diagnosed Alzheimer's disease. And that leads into as well diabetes. So the risk of dementia increases with the duration and severity of the diabetes. Overall, type 2 diabetes is a clear risk factor for the development of future dementias. However, whether any particular medication improves this risk is unclear. Infrequent social contact is the next modifiable risk factor. Less social contact increases the risk of dementia. And a meta-analysis of over 812,000 people found that dementia risk to be elevated in lifelong single and widowed people compared to married people. And this association was consistent in different sociocultural settings. And then finally, the newly added modifiable risk factors include excessive alcohol consumption. So heavy drinking is associated with brain changes, cognitive impairment, and dementia. And there's an increasing body of evidence is emerging on alcohol's relationship with cognition and dementia. Head injuries was also added as a modifiable risk factor. Head injuries really related to motor vehicle accidents, military injuries, sports injuries. And we know that risk of dementia increases with each concussion. And finally, air pollution. So air pollution and particulate pollutants are associated with poor health outcomes and negative impact or effect on the brain. So this figure is pulled directly from the report on page 416, and it's figure 2. And this figure summarizes possible mechanisms to prevent dementia, considering neuropathology and cognitive reserve. When we think about neuropathology, we consider protein accumulation in the brain and vascular damage that can contribute to dementia. Reserve has been defined as a concept of accounting for the differences between an individual's clinical picture, how they are presenting, and their neuropathology. Cognitive reserve is changeable. So considering the modifiable risk factors over the life course can predict dementia. For example, early life factors like education can affect cognitive reserve. More women are likely to develop dementia, and this may be due to decreased education. People in good health may be able to sustain more neuropathology without cognitive impairment. So this figure shows how controlling for the modifiable risk factors on the left side can have an impact on neuropathology and cognitive reserve. So for example, by minimizing diabetes, treating hypertension, preventing head injury, stopping smoking, reducing air pollution, and reducing midlife obesity, we can have an impact on reducing neuropathology. Treating hearing impairments, maintaining frequent social contact, and attaining higher level of education can have an impact on maintaining or increasing cognitive reserve. And what we know is that maintaining frequent exercise, reducing the occurrence of depression, and avoiding excessive alcohol can impact both neuropathology and cognitive reserve. Of interest, a small study on midlife activities found that travel, social outings, playing music, art, physical activity, reading, and speaking a second language were all associated with maintaining cognition independent of education and occupations in late life. So the activities we choose to do in midlife matter, and it's not all about the education you receive in early childhood. So life course is important when we consider risk of dementia. And so as mentioned, we want to risk factors in early, mid, and later life can contribute to dementia risk. This visual, figure 7 from page 428 in the report, highlights percentage reduction in dementia prevalence if the risk factor is eliminated. So for example, what you'll see in early life, if you can provide education, you can do a percentage reduction of dementia prevalence by 7%. In midlife, targeting hearing loss reduces that dementia prevalence by 8%. And so that's why we talk about hearing loss being the number one modifiable risk factor. Traumatic brain injury can be reduced by 3%, and addressing alcohol, obesity, and hypertension is 2% each. In later life, addressing smoking can reduce percentage reduction of dementia prevalence by 5%, addressing depression 4%, social isolation 4%, and again, physical activity and air pollution 2% each, and 1% with diabetes. So as you follow this reverse S-curve, you see that the modifiable risk factors attribute for 40% of dementias, and that 60% of risks are still unknown. I like this visual because it highlights that it is not hopeless. Even in late life, there are modifiable factors that can be addressed to reduce risk. Using this evidence, it might assist clinicians with targeting interventions and starting discussions with clients. For example, we know that getting people engaged and physically active is helpful. Addressing depression, recognizing it and treating it will address dementia risk. This visual also highlights the need to consider population cohorts and preventative health care. There's a need to take an upstream approach with the younger population. We need to work on health promotion in midlife, which many of us clinicians on the call may be today, or our family members, but also that there are changes that can be made in later life to address dementia risk as well. The report has both population-wide and individual recommended strategies for dementia risk. Recommended population-wide strategies include prioritizing childhood education for all worldwide, implementing social public health policies that reduce hypertension risk across the entire population, developing policies that encourage social, cognitive, and physical activity across the life course for all. And there really isn't any evidence for specific activities being more protective. We need to scrutinize the risk for hearing loss throughout the life course and reduce this risk of exposure or this risk factor. We need to reduce the risk for serious brain trauma in relevant settings, including occupational settings and in transportation. The recommendations are that national and international policies to reduce population exposure to air pollution, and we need to continue to strengthen national and international efforts to reduce exposure to smoking, both in children and adults. with an attempt to reduce uptake of smoking, but also to encourage smoking cessation. When we think at it in strategies targeted on individuals, we really want to focus and include things like treating hypertension, aiming for systolic blood pressure under 130, using hearing aids for hearing loss. We need to help people wear hearing aids, as many people find them unacceptable, they're too difficult to use, or they're ineffective. We need to try to avoid or discourage drinking 21 or more units of alcohol per week. The recommendation is to prevent head trauma where an individual is at high risk. Stopping smoking is beneficial regardless of age. So we're making sure that we're having those discussions with the individuals that we support. Trying to reduce obesity and the linked condition of diabetes by making sure that healthy food choices are available and there is an environment that allows for increased movement. And making sure that we're trying to sustain midlife and potentially late life physical activity as well. It's important to note that not all dementia will be prevented. And it's important to people living with dementia and their care partners that they have an accurate diagnosis. We know that this diagnosis is a gateway often to interventions and services that many of us offer. It helps for planning the future, supports the family, and it also contributes to research as well. Once an accurate diagnosis is made, recommended interventions include providing holistic care. Care for people with dementia should address physical and mental health, social care, and support. We know that most people with dementia have other illnesses, and they may struggle to look after their health, and they might result in potentially preventable hospitalizations. So providing that holistic approach is key. Managing neuropsychiatric symptoms. So psychotropic medications are often ineffective and may have severe adverse effects. There is no new evidence of medication effectiveness on neuropsychiatric symptoms, but evidence is slowly accumulating for the effectiveness of person-centered, evidence-based psychosocial interventions, many of which us on the call today provide. And we need to do care for the caregiver. Specific interventions for family care partners have long-lasting effects. They impact symptoms of depression and anxiety. They help to improve quality of life, and they're seen to be cost-effective, helping to save money in the healthcare system. So that was a quick whirlwind highlight of the Dementia Prevention, Intervention, and Care 2020 report of the Lancet Commission. The key messages really include that we need to be modifying these 12 risk factors will help to prevent and delay 40% of dementias. We need to be ambitious about prevention. Prevention is about policy development, and we need to have interventions that are targeted not only at population-wide level, but also targeted at individuals. Specific actions for risk factors need to be addressed across the lifespan. So contributions to the risk and mitigation of dementia begin early in life and continue throughout life. So it's never too early or too late to start looking at reducing dementia risk. We need to tackle inequality. We need to be mindful of low and middle income countries and take a worldwide approach, thinking about air pollution, access to education, and how other countries may be addressing these risk factors. And we need to protect people living with dementia. We need to make sure that we're providing holistic care, managing neuropsychiatric symptoms, and caring for family caregivers. Going to highlight, and I believe that the link to the report has been put into the chat box, but this is the references. And if there's any comments or questions, we will open that up.
So we did have a question earlier about alcohol use and the guidelines, which we have addressed in the chat box. But just as a brief summary of that, units of alcohol, when we're talking about that, we're talking about 2 to 3 units of alcohol is equivalent to a beer or a wine, a glass of wine or a cup of beer, depending on alcohol content, etc. 21 units is approximately 2 bottles of wine in a week. And on page 423 of the Lancet report, there is more information on those guidelines.
Great, thank you, Jackie.
Any other questions for the speaker? Okay, so I'm going to go ahead and just draw your attention to a few upcoming education opportunities. In October, we've got Dr. Jeff Daniel coming to the practice short to speak to us about the Canadian guidelines on prevention, assessment, and treatment of depression among older adults. And that was updated in June of this year. So again, that's going to be at 8:30 via Zoom webinar like we're meeting today, and it's about a half an hour. So Allison will put that link for registration in the chat box. Next, we've got the North Simcoe Muskoka Dementia Network Conference 2021, Dementia Through COVID and Beyond. That's coming on Wednesday, October 27th. It's a free event and it will be virtual again this year. So that registration link will be in the chat box as well. Actually, you will be asked to speak with Taro from the Alzheimer's Society for registration. And finally, we've got the PRC Fall Education Sessions. We're back up and running virtually for the fall. So I would urge you to use that QR code down at the bottom of the screen. That will take you right to the registration page, or you can click the link that we'll put in the chat box. But we do have a number of events coming up. So we've got Positive Approach to Care. That will be September the 28th of this month. We've got Seniors Mental Health. Days 1 and 2, October 4th and 5th, and the third day for regulated professionals on October the 9th. And Gentle Persuasive Approach is happening October 13th. So registration for these sessions is open and are being sponsored by NSMSGS. So I want to thank everybody for attending today. And if you're joining us via the recorded session, thank you for watching.